Hi, my name is Amanda Montero. I am a palliative care social worker, and today I'm joined by my colleague, Dr. Jacqueline Sheehan, and we'll be talking about grief and bereavement. We have no disclosures, but we would like to acknowledge that this presentation has been adapted and enhanced from works from our colleague, Jane Knowles and Dr. Ankita Mehta. The objective of today's presentation is to give you some more understanding of the vocabulary related to grief and bereavement, recognizing that this grief and bereavement are very common and natural processes in the human experience of loss. Introducing you to some theoretical models to give a little bit more understanding into grief as an adaptive process. Understanding anticipatory grief and that phenomena as someone is confronting their own mortality or as death nears. Identifying grief-related reactions, what is quote unquote normal or adaptive versus when we need to be concerned or start thinking about other things, and really defining or distinguishing between acute grief, uncomplicated grief, and what complicated or prolonged grief disorder looks like. So some of our vocabulary, loss. If we think about being attached to an object or a person, loss is the separation from that object or person. Grief is the emotional reaction. So how does that present? It can be sadness, anger, a lot of different things, but it's the emotional distress associated with that loss or change, because grief is synonymous with change. Even if it's not a death, every change has a grief response. Mourning, it is the process of incorporating the loss. It's the outward experience of grief, but it is the process of it. And then bereavement is what we refer to when it is the state of having experienced a loss of a loved one or a significant other. It's characterized by expressions or feelings of grief, and it really goes for it's an undefined period of mourning, but the result is a gradual adaptation to life without the loved one. If we think of grief as an active adaptive process, then what we think about when it's not adaptive, when it's maladaptive. And the DSM provides one diagnosis, which is prolonged grief disorder, also known as complicated grief. This is when normal grief is kind of heightened to a significant state where it impairs functioning. And this continuation of distressing grief response lasts longer than 12 months. Hallmarks are intense longing, yearning, sometimes a preoccupation and thoughts related to the loved one or the circumstances of the death. It can be concurrent with other psychiatric disorders, but a professional intervention is usually recommended, especially if it results in a lack of being able to function on some level because of the grief itself. Other terms that can kind of fall under this umbrella of maladaptive grief: chronic grief, delayed grief, exaggerated grief, or even mass grief. But there's only one diagnosis per the DSM, prolonged grief disorder. So grief is a normal adaptive process. So how do we understand that? It really begins before death. It's experienced by patients, families, friends, healthcare providers. It isn't predictable. You can't anticipate grief or how it will show up. There are multiple tasks and phases associated as you go through this adaptive process. And when we talk about normal or healthy or adaptive, it leads to the successful integration of or adjustment to the loss, but it's the integration of the loss. Some of the models that exist have helped to try to explain grief as this experience, this lived experience. Most famously, obviously, Kubler-Ross's stage theories. We also have task theories, phase theories, which aligns with the attachment theory, and then postmodern theories, dual process model and continuing bonds, which I think lend really nicely to really assisting patients and families understanding how the grief process works in a more organic way. So the classic stage theory of denial, anger, bargaining, depression, and acceptance, this has been around for a very long time. it was once thought to be a linear process, which we know is not the case. People can go back and forth between these stages throughout their grief cycle. When someone's in a period of denial and having a hard time confronting, or this idea of magical thinking and they can't confront it, it's really about information sharing and communication. And this will have to happen repeatedly until, it moves into another stage of the grief. Anger, bargaining, depression, these are all very normal facets of grief. They require a lot of emotional support, and acceptance, guidance of what to do next, really open to logistically what should happen next, having a plan for what happens next. And then recently there is this new kind of sixth stage that was created by David Kessler. It's hope, it's finding meaning. And really what it is, it's the integration, because even if you're accepting a loss, it doesn't mean you're integrating it. So it's really about this integration of the loss in your life moving forward. One of the postmodern theories that I think lends itself really well when working with patients is the dual process model. It really allows for grief not to be, it's not universal. Everyone is different. It's going to look different. And where the stage and phase models assume passivity, that you just happen through them, this is a more active process. And it's basically a balance where you're oscillating between loss-oriented and restorative activities. Loss or grief, feeling the grief, doing grief work, having those feelings of grief, and then also giving yourself a break. And especially in the acute grief period, you might spend more time in this loss-oriented, but you still need to give yourself a break. And as time progresses, you might find yourself spending less time in the loss-oriented, more in the restoration-oriented, but it really focused on dosing grief, and that we can liken it to self-care. You can't continue to give care and have an empty cup. Grieving acutely for a significant amount of time actually has such a negative impact that it is okay to have these restorative periods, and providing that psychoeducation to families and patients is really helpful, especially to families. And there are benefits to this and incorporating it. So grieving as death nears, the idea of anticipatory grief, which so often we have as soon as, say, goals of care conversation, and we've decided comfort measures. Families and patients have started to confront they're at their end of life, whatever time that might be, and we might and very often see these reflected in anticipatory grief, thinking about what's going to happen, anxieties associated, what's going to happen, fear, what's going to happen. And that's really our anticipatory grief period that we can support throughout an admission or even outpatient with follow-up. So anticipatory grief is when someone's receiving any sort of life-limiting illness, serious illness, that they're forced to confront their own mortality, or the mortality is coming maybe sooner than they expected. It's experienced by patients and families. It can also be experienced by providers. Again, it's just triggered by the awareness that death is impending. It represents this tension between holding on and letting go. And it's that tension that can be very emotionally provoking for a lot of people. Again, patients, families, friends, and even providers. And it is something that we deal with so often, especially in the inpatient setting. The symptoms are not explained by other somatic symptoms. And really how someone grieves in the anticipatory period really is predictive of how they'll cope. So this is a really rich opportunity, not only to provide support, but also to assess if there are risk factors associated with complicated grief. Having anticipatory grief doesn't necessarily diminish the intensity of grief after the loss of a loved one, but it does help provide supports that could mitigate any risk factors if someone is at risk of complicated grief. So how do we support? Really providing the dying person or the family a way to begin absorbing in a safe and supported space, absorbing the reality of the death. Offer opportunities to prepare, helping reframe, helping support, reinforce their strengths and sense of resilience, and really help with the interdisciplinary team to help with coping during this period. Symptoms very similar to grief responses: separation anxiety, being alone, denial, sadness, disappointment, sometimes rehearsal of the loss, hypervigilance when we see family members sitting at the bedside, unable to walk away, guilt, exhaustion, fatigue. It basically runs the gamut. So what can we do? We can enhance dignity at the end of life, really promote entering in life review, narrative, meaning making, reframing and cognitive restructuring, psychoeducation, what to expect, normalizing and validating an individual's experience, sometimes short or brief family interventions when there's a complex dynamic, if it's appropriate. Again, self-care practices, or even this is a great opportunity to bring in the dual process model of, giving space to grieve as well as giving yourself the space to do something that brings you joy and legacy work. So grief after the loss, this acute grief period, this is where things can be really, really intense, and there can be cultural differences, there can be gender differences in how someone responds. It is, you can have uncomplicated or normal grief, which these are all normal. Big reactions, sadness, anger, again, anything like that is a very normal part of the grief period. Post-death, you can also, after a period of time, a year, if these persist, this complicated or prolonged grief disorder, you can also have bereavement-related anxiety or depression or major depressive disorder, or even PTSD, depending on what the circumstances of the death. Oftentimes in traumatic death or high symptom burden at the end of life, it can be very traumatic for families and loved ones, and it can stay with them. As well as other adjustment disorders for the adjustment of new roles, new responsibilities, life after the loved one. So we have a case. In this case, a 70-year-old woman with metastatic breast cancer recently died at home while receiving home hospice care. Following her death, the hospice team reaches out to the husband who cared for her at home during this time. Which of the following would not be expected as a part of a typical acute grief reaction? A, frequently tearful. B, questioning meaning of life and death. C, experiencing nightmares. D, difficulty concentrating on tasks. The answer is C, experiencing nightmares. This might be indicative of other things going on, maybe some trauma, other things that we should be exploring further. Acute grief is, again, right after this initial loss. It can be the most intense. There can also be feelings that can confuse people, feelings of grief, of joy, of peace. And sometimes that, normalizing and validating that is really therapeutic for individuals, because it seems so out of line with what we anticipate grief being: sadness, sometimes anger. But it can also lead to relief or joy if there's been a prolonged illness. Emotions can be really intense. We really need to make sure we're not judging people by their reaction when someone has just lost a loved one. Depending on their attachment or their quality of their relationship, it can really influence what that initial response or the intensity is. This is really, in this acute grief period, it's really focused on the physical separation. Having someone with them and having such meaning, and then all of a sudden them not being there, it's overcoming that loss. And to remain uncomplicated, again, you're continuing to, after this acute period of intensity, it's going to continue to lessen. And if you're going through it and moving through your grief, you'll eventually be able to integrate it. Typically, that won't really happen until after the first year, 18 months. But in the very first few months, it'll be pretty acute. And that's normal. Speaking of normal or uncomplicated grief, these are a range of feelings that they have varied levels of intensity. Even if someone doesn't have intense reactions, it doesn't mean that they're not grieving. A lot of this is subjective, and we also have to approach it with a cultural lens as well. It is really characterized by an individual's ability to adapt. And again, someone can have intense emotions, have a lot of feelings, can maybe change some certain behaviors. But whatever it is they're doing in the long term, and they're working towards adapting, accepting and adapting that loss, that is still embodied or described as uncomplicated or normal grief, because we're really the adaptive process, that it's really the goal is culminating into the integration of the loss. If we see things that might be, before we move on, so tasks of grief, some of the tasks of grief that that we move through, just like in the stages, is accepting the reality of the loss, processing the pain and grief, adjusting to an environment without the lost person, and then this idea of integration or reinvesting in the new reality, which is very much the integration piece. How are you moving forward? How are you establishing or maintaining the connections you've had? These are all indicative of normal grief processes. Symptoms can be somatic, physical in the throat, shortness of breath, feelings of nausea, loss of energy, intrapsychic, disorientation, sadness, depression, anxiety, and then also behavioral, crying, loss of interest in certain activities for a short period of time, hostile outburst, or easily irritated. Safety should be considered if there are physical and mental health risks, or if behaviors that are maladaptive or poor coping, like drinking, drug use, are coming into play. Should be really assessed for. Again, the grief reactions, so the symptoms, but the reactions are also physical. Sometimes it can present as headaches, muscle aches, pain over the body, not eating, sadness, anger, powerlessness, relief, emancipation. Again, these often conflicting feelings can happen at the same time and vacillate between one another, which is very confusing. Cognitive reactions, obsessive thinking, fantasizing, confusion, disorientation, and playing back the circumstances of the death over and over. And then spiritual reactions. We enter into a lot of existential crises, especially towards the end of life, kind of finding meaning in life, what our impact was in life, and really coming to terms with whatever spiritual framework you have in this period of time. So a lot of existential distress can present. We also want to say that grief doesn't happen in a silo. So it's not just an individual, it is the entire family system that experiences. And some signs of a grieving family might be changes in communication within family members. Maybe patterns change, maybe people emotionally cut off from each other. Maybe they're seeking reconnection in the final days to restore whatever relationship once was. We see a lot of changes in structural. So the hierarchy might change depending on the loved one who's dying, what their position and role was. And that might cause a family to really shift and have a lot of challenge with the loss of that person because of their, not only their attachment, but what they were doing for the family. If they were the sole breadwinner, or they were always the matriarch or the family. There's also triangulation that happens. Sometimes coping styles are different, or everyone's in a different space. And so it really can lead to conflict. It can lead to acting out. So we really want to be aware of what these structural changes are in the setting of grief. And then as we assess kind of go forward any sort of risk, we also want to look outside of the family structure. What are the support systems to the bereaved individuals? Are they supportive relationships? Are they not? Do they not have anyone? Or are they overprotected? These are things that can kind of give insight into who's going to help and support after the loss. Passing on to Dr. Sheehan.
And so next, moving on to complicated grief, what that can look like and mean. So complicated grief itself can be described as a derailment in terms of a person's accommodation to the grief and the grieving process itself. It's pretty common with 10 to 20% of bereaved experiencing some form of complicated grief. A person experiencing this will appear stuck in their grieving, where they're really unable to adapt and will have marked functional impairments evident in their day-to-day life. It will be defined as the persistence of these acute grief reactions, along with a marked functional impairment present for at least 6 months or up to 12 months post the loss, and it often requires professional intervention to treat. There are a few different types of complicated grief included here at the bottom, like delayed or exaggerated grief reactions, as well as mass grief reactions. And complicated grief leading to a disorder is known as prolonged grief disorder. It's characterized by intense longing or yearning for the deceased person, but also with this preoccupation with thoughts and memories of the deceased person. Symptoms, again, you're going to have intense emotional pain and distress, a range of emotions from sadness, anger, guilt, but these symptoms exceed the norm and cause impairment in at least one or more functional areas and need to be present for at least 6 months before it can be diagnosed. So factors that can influence complicated grief include the context of the loss itself, the meaning the person associates with the loss, how their relationship with the deceased changes, and how they regulate their emotional and coping processes in the aftermath. And there's lots of risk factors that will increase a person's chance for developing complicated grief to be aware of. Some ones to be mindful of, especially if it's an unexpected death or a violent or unnatural death. If the person has a prior history of depression or anxiety to begin with. Also, people with lower income, lower education levels, or when the death is their child or their partner. And another type of loss to note is disenfranchised loss, which involves grief that may not be recognized, validated, or supported. They may be losses that may not be deemed worthy of support, like others. So ones that we think of is maybe people with unrecognized relationships, such as LGBTQ plus patients and partners. It can also include those dealing with stigma associated with the death, maybe when the death is related to HIV or AIDS or alcohol or substance use disorder. And for those experiencing and dealing with complicated grief, we see prolonged grief symptoms that lead to this significant impairment or functioning in their day-to-day life. We talked earlier about how they really remain stuck, can have these real persistent, intense emotional or physiological responses, and a maladaptive rumination about any distressing parts of the loss. Really striking behaviors can include big or radical life changes they make, and maybe self-destructive impulses and behaviors as well. So with our same case of a 70-year-old woman with metastatic breast cancer who recently died at home while receiving home hospice care, and the team reaches out to her husband after her death and identifying which of the following factors can lead to an increased risk of developing a complicated or prolonged grief disorder. So A, being the primary caregiver, B, a higher level education, C, an expected death, or D, hospice enrollment. And based on what we discussed earlier, being a partner, being a primary caregiver will put him at an increased risk for developing complicated grief. And whereas the other factors here would not, and in fact would be protective. Ones that are risk factors are if he had lower level of education or it was an unexpected death. So following on from risk factors for developing complicated grief, some protective factors that are important to know include hospice enrollment and utilization, spiritual support prior to bereavement, and overall satisfaction with palliative care and palliative involvement. And next, we'll go through some assessment tools that can help identify individuals that may be experiencing complicated grief. So we can screen for complicated grief using the brief grief questionnaire, and complicated grief can be differentiated from bereavement-related depression and anxiety by using the second one listed here, the inventory of complicated grief. So to get a sense of what these tools look like and involve, first, the Brief Grief Questionnaire is a 5-item screening tool scored on a scale from 0 to 2, from not at all to somewhat to a lot. Really, the questions here involve looking for any trouble they're having, accepting the death of their loved one, and maybe how the grief is interfering with their life. Are there things they're avoiding doing after the death, and how it's impacting other relationships in their lives. And a score of 5 or more is going to trigger or warrant a referral to a mental health professional. And second, this is the inventory of complicated grief to help distinguish the symptoms of complicated grief from other psychological responses to bereavement. So it's a very detailed screening tool. It has 19 questions, again, also on a scale to help identify those at risk for enduring distress and disruption in their daily lives. So just two to be mindful of. And although grief experts generally agree that a small minority of bereaved people will experience severe and persistent and disabling grief, there's also some discussion among experts as to whether or not normal grief processes should be considered pathological. So it's important to recognize and be aware that the disordered response that can be seen in complicated grief, known as prolonged grief disorder, is recognized as a mental health disorder per DSM and ICD. So looking closely at our geriatric population, how grief can impact them. So there is not a lot of research looking at complicated grief in older adults, despite there being a significant proportion, anywhere from 10 to 40% of older adults who continue to grieve for extended periods of time and experience complicated grief. And this can be significant for these older adults. So looking at numbers for this, we can see how older adults can experience really cumulative losses in their life, and especially later in their life. So almost 40% of those who are aged 75 to 80 years range have experienced already the loss of their spouse or partner, and almost 20% will experience the loss of their child. So this bereavement is also associated with increased morbidity and mortality, as well as increased healthcare utilization, which can be even more pronounced in the geriatric population. Especially those with prolonged grief disorder can be left with long-term functional impairments, increased risk of physical, mental health problems, which are highlighted here at the bottom. So things like increased cardiovascular problems, major depression, and even substance use. There can be many other types of loss and grief that the geriatric client can experience, from dealing with their own functional, sensory, and health status decline with age and with time, their loss of independence, their loss of autonomy, changes in their living situation, loss of financial standing, maybe loss of social status and networks, in addition to the loss of significant others, which we spoke about. And spousal loss is, regardless, one of the most challenging life-changing experiences, especially for the older adult, and the majority will lose a spouse later in life, with women experiencing this loss more than men. It can impact their own health, their own well-being, disrupting routines, leading to increased loneliness, really leaving them to figure out a new independence, a new identity, and new relationships much later in life. And we can see that newly widowed older adults experience more depression, despair, and distress. They also can face higher rates of being institutionalized, increased mortality risk compared to their non-bereaved peers. Research is pretty limited in this population, as we mentioned earlier, but most spousal bereavement studies that exist look at female perspective widowhood and can be seen more so as a women's health issue. And as individuals live longer, the death of an adult child is not as uncommon, but it's typically not an expected or anticipated loss. And this loss can lead to increased risk of developing complicated grief. It significantly correlates with higher depression scores, with the loss felt across a lot of different domains for these people. One we don't commonly think of in terms of impact, but the impact of the loss of a sibling can be profound and complicated. These relationships can be complex as well, ranging from very positive to very negative, and this can dictate the type of grief response they may have. It can also make individuals start to feel older themselves, maybe think about their own mortality and death. So things that can help include giving your geriatric client time to tell their story, having the willingness and the patience to listen, as many report that family friends were uncomfortable or didn't know what to say in hearing about their loss, especially their loss of an adult child. And this storytelling also allows for contextual grounding. It can help improve their overall quality of life and helps give meaning to the life of the person they may have lost. So lastly, looking at things we as providers can do to support. So for patients and for families, it's important and helpful to attend to their psychological, their spiritual, and existential pain, starting with open-ended questions to see how they're dealing and coping with it all. We can help them find meaning by sharing their life stories, creating memory books, videos, really legacy work, which can increase their sense of control of the situation. And it's also beneficial to encourage and help them to identify social activities, involvement, if appropriate, spiritual and religious activities, and overall healthy behaviors for coping. And the goal is to help them achieve an appropriate death, and when their time comes, that will match their values, goals, and their lifestyle. And when speaking to those experiencing loss, it's important to acknowledge the loss and avoid minimizing it. Again, the goal always is to listen, helping them express emotion, and involving a chaplain, clergy, and social work as needed and as helpful. We often do and recommend making a condolence call, which is an opportunity to provide information on bereavement resources as well. And for bereaved individuals who don't have psychiatric disorders, there's no real strong evidence for the use of psychotropic medications like benzodiazepines or antidepressants in these individuals. For those bereaved individuals experiencing insomnia, we recommend sleep hygiene resources or possibly a sleep aid like melatonin. For patients who have prolonged grief disorder, treatment includes a specific prolonged grief disorder therapy or CBT, cognitive behavioral therapy, that's adapted for prolonged grief disorder. And this is delivered by a mental health professional and specialist. And last slides here are resources with different websites that may be helpful for you, for your patients' families, if providing them more information about next steps or supports that they can avail of. And these are different books related to grief for adults, but also for children across a range of different ages and how you speak to them or start to speak to them about death. And these are our references, and thank you very much for listening.